Welcome to Bear in Mind, the Brown Psychiatry Podcast, clear, current content about mental health. I am the host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm Dr. Camila, Cosmo, Psychiatrist and Co-Editor-in-Chief.
And I am Dr. Meghan Kulak, Psychiatry Resident and Script Editor for today's episode.
And I am Brooke Huminski. I'm a psychotherapist in Providence, Rhode Island. I am the guest for today's episode.
First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. According to the National Eating Disorders Association, around 28.8 million Americans will experience eating disorders like anorexia, bulimia, and binge eating, often accompanied by a negative body image, unsafe behaviors, and mental health issues like anxiety and depression.
These disorders can also result in physical complications and elevated risks of death by suicide or other causes compared to the general population. Eating disorders are common and have a significant impact on the affected individuals, their family members, and the community.
To learn more about eating disorders, we invited Brooke Huminski, a licensed independent clinical social worker with a wealth of knowledge and expertise in eating disorders, body acceptance, and perfectionism. Thank you so much for joining us.
Thank you so much for having me.
It's our pleasure.
So eating disorders such as anorexia, bulimia, and binge eating disorders have many similarities. Can you please help us understand the key differences among these disorders?
Absolutely. So with anorexia, there is this relentless pursuit of thinness. There is severe restriction of food intake through dieting and fasting. There is an intense fear of weight gain, despite someone being at a persistently low weight. There's a characteristic rigidity around food that also can extend to other areas of one's life. There's often a denial of hunger. There's an avoidance of social gatherings. There's saying that one's eaten when they haven't. There's a preoccupation with thoughts about food, and this can get worse the more restriction occurs. This can include exercising excessively. There's also a subtype of anorexia that includes purging, binging and purging, which is different from bulimia because the person still maintains a low body weight. And then there's a pure restriction type.
Oh, I see.
In bulimia, it's a bit different. So there are episodes of binging in which someone consumes a large amount of food over a short period of time. So say 2 hours, an objectively large amount of food. And this is followed by some type of compensatory behavior. The most common one known is purging by vomiting. However, there are other ones. That includes excessive exercising, fasting, laxative use, and diuretics. Oftentimes, there are feelings of shame and secrecy. These episodes are done in secret. Lots of money can be spent on food. And overall, someone might feel disgusted with themselves and really a big barrier to seeking help.
We see.
Binge eating disorder is similar to bulimia, in which the person also consumes a large quantity of food, larger than one we consider, and afterwards will have the same feelings of shame and overwhelm and loss of control. Also might be done in hiding, out of view of family members, out of view of people that care about them. This is not followed by compensatory behaviors, though it carries the same level of suffering as anorexia, bulimia, and all of these may happen in secret.
And how can one tell the difference between a health eating and an eating disorder?
Sure. So in our culture today, it's really difficult. We live in a culture that is quite disordered around food.
It's true.
So when someone is experiencing a healthy relationship with food, they have flexibility. They're able to go out to eat with their friends, pick food off the menu, and not really think much about it afterwards. They're able to participate in social gatherings like holidays and not have to prepare ahead of time or feel guilt for eating perhaps more on a holiday like Thanksgiving, where we all tend to eat more and enjoy food. Thoughts of food aren't pervasive through one's life. There aren't food categories that people are saying I cannot have. Whereas in unhealthy eating, disordered eating, someone has rigidity around food. So they're excluding large quantities of food. They're going long hours of the day without eating. They may have certain rules about how much food they can have, how much food type they can have in 1 week. So for example, I can only have ice cream 1 time a week. And if I have ice cream more than that, I'm a horrible person, or I'm going to gain so much weight. There are ways that food connects us to each other, right? Food is not just about nutrition, though that is, of course, part of it. Someone with an eating disorder may only see food in this narrow perspective of how much is it going to impact my health? How much is it going to impact my weight? How much is it going to impact my sense of self? And then in terms of eating and exercise, we often hear from people in our culture, perhaps even without eating disorders, oh, I exercised for a certain amount of hours today. Now I can eat dinner, or now I can have that dessert. So that would be unhealthy relationship with food versus I am joyfully participating in movement to help my body and to lift my spirits versus I am doing something to earn my food.
Thank you for that. I think there's also a common misconception that eating disorders primarily affect young white females. Who exactly is at risk of developing an eating disorder? Do you have to be underweight to have an eating disorder?
Those are great questions, and I'll try to answer them one by one. I'll add thin female also. That is the stereotype, right? And that is such a misconception that is harmful to people suffering with eating disorders. Eating disorders can affect people from any socioeconomic class, any race, any gender, any ethnicity, any age. We often miss eating disorders in people who are older or middle-aged.
Indeed.
And there's statistics that we miss people with eating disorders who are Hispanic, who are Black. We tend not to diagnose the same in Black women as we do in white women, even if the same clinical presentation is there. This leads to people going longer without a diagnosis and therefore without treatment. So then when they actually seek treatment, they're at a higher risk of medical complications, increased suffering. And then while women do experience eating disorders at a higher rate than men do experience eating disorders and actually subclinically experience the same rate of eating disorders as women. And men might not be as eager to seek treatment because of stereotypes in our culture. And again, they also might be missed in routine screenings. A big point I want to make is that the majority of eating disorder presentations are in people of average body weights or higher body weights. It's a small percentage of people with eating disorders who are underweight. So we cannot tell if someone has an eating disorder by looking at them. We cannot tell if someone is malnourished just by looking at them. This is something I really emphasize when I'm working with people I'm training or supervising because it is so common. It's such a common stereotype.
True. So studies have connected exposure to an appearance ideal or a beauty standard to the development of eating disorders. What can we do as individuals and as a society to promote healthy body image and self-esteem?
In our culture, it's a bit of an uphill battle, yet we are making strides. There is a concept around body diversity that is pretty straightforward when we think about it, yet hard when we think about the thin ideal that is so pervasive. So we wouldn't expect all breeds of dogs to look the same, right? Yet we have this idea that all people should look the same, even though we have different body types, different genetics, different family history. So that is one way as adults, and even teaching children and adolescents how to build an idea of body diversity, especially when we're exposed to different images or different pieces of social media. We can notice and not perpetuate weight stigma and fat shaming. This is also embedded into our culture. It's embedded into some places in schools and medicine. It's embedded into bullying at school. We can teach our children not to make comments based on people's appearance. And we can do the same, right? It's very, very common to hear from someone or to even make a comment without thinking, oh, that person's weight has changed, let me comment on it. And that is something really to move away from. And instead, for example, I noticed you're really kind today, or I really value you as a friend, or what's going on in your life, if there is a concern. We can think about this concept and movement about health at every size, which is thinking about different health factors that exist and that we can be a part of that aren't solely based on someone's size. And this is a movement that's built more esteem and more progress in the field and works alongside this non-diet approach to help people feel more comfortable in their bodies and comfortable in our culture. There's some talk at times around body positivity. When I'm working with clients, sometimes that's too far of a stretch, right? To move from really body hatred or body dissatisfaction. The space in the middle is body neutrality and body acceptance. So can you live in this body that you really don't have too much control over in terms of genetics, or say you develop a medical illness at some point in your life, or you're aging? Our bodies are meant to change. So practicing body neutrality would be, okay, this is the body I'm in, this is the recovery body I'm in, and also who am I outside of that body? What are my values? Who am I as a person? What are my relationships? How can I foster connection? Eating disorders are bred and continue in disconnection. We can think about how we can teach children in our culture about media literacy. This is a big one in terms of all the media we consume as adults too, somewhat mindlessly, right? But also our children have less capacity sometimes to filter and acknowledge what they're seeing is not reality. And the influencers they're seeing aren't necessarily experts in these areas, though they may present themselves with an abundance of confidence that can really be tricky and damaging. So parents, educators, clinicians, when I work with my patients, I'll help them either take breaks from social media, which we know can help reduce body dissatisfaction, even taking a 1-week break, and changing their feed around. So who are they following?
Right.
And who can they start taking away? And who can they start adding? Adding more body positive folks, adding people in different body shapes and sizes, adding people of different interests. There's a number of different ways. Those are a few to get started.
Talking about social medias, what is the role of social media in the risk of developing an eating disorder?
Yeah, social media is a perfect storm for patients with eating disorders. It alone does not create eating disorders. Otherwise, everyone who consumes social media would have an eating disorder. However, for those patients that I work with, they sometimes find these people on social media who are perpetuating, who might be very sick themselves, and then the algorithms feed them more of that, and then we have to go through what is that doing to them? What is that behavior actually getting for them versus moving to a more recovery-oriented space? TikTok has been trying, other social media platforms have been trying to help use different filters, use different ways. You can go into the app and there's instructions online on how to really sort out some of the content. However, sometimes I've had clients actually just erase their social media and start over, like create a brand new account when they're in recovery, if they choose to stay on social media. And what I found with some of my patients is that they'll actually not be as engaged in social media as some of my patients without eating disorders, and doing that deliberately. Though social media isn't going away, it's here. And there are different ways we can, certainly protect and guide adolescents through this and involve it in the conversation, right? We can't assume that, social media is bad, don't do it, stop forever. We have to acknowledge this as part of the culture and also a part of connection. And there are ways that social media has brought people together. There are ways that people find individuals that they may not meet in real life who have been in recovery or further along in their recovery journey. And then they see examples of that, and they might not see that in their day-to-day school situation or many groups.
Yeah, this is a very good point. And we saw this a lot during the pandemic too, how helpful that was. Yeah, to feel connected and like be in contact with other people. So thank you for that. There has been a lot of talk since the start of the COVID-19 pandemic about weight gain and body image. So how has the COVID-19 pandemic impacted people with eating disorders?
So COVID-19, again, a perfect storm of isolation, of uncertainty, of loss of control, times where food needed to be hoarded in the home. And you can imagine if someone is struggling with bulimia or binge eating disorder and maybe working with the treatment team to try to keep certain trigger foods in moderation, all of a sudden they can only go to the grocery store once a month. And then they have all this opportunity and all these triggers. Conversely, people who were more prone to restriction, feeling overwhelmed, feeling out of control, feeling like the routines were changed, which can be a trigger in anorexia, would then turn more into a scarcity mindset and start restricting their food. We also saw a lot of over-exercising. Oh, yeah. I think we can all remember, especially those early days, everyone outside frantically walking their dogs excessively. Just the ways the ways that we were all under so much stress.
Right.
Anxiety increased, depression increased, and therefore eating disorders increased. The unfortunate part with that was then treatment providers, treatment centers became overwhelmed. Yeah. And so eating disorder rates went up. Clinically in my practice, I saw more requests for patients to be seen, had a harder time getting people into treatment centers who were then impacted by the public health measures they had to take to keep people safe with COVID. And with regards to the COVID-19, right, this gaining the COVID-19, I think it really speaks to the dysfunction of our culture, that at a time where people were dying and healthcare workers were out there in the front lines, that we were really focusing on our weight, right? Have some compassion, right? So people aren't choosing this. This is the water we swim in. And also, something to consider of really a distraction from some of the suffering and the fear and the uncertainty.
So I'm wondering, for those listening who may be concerned about a family member or friend with an eating disorder, what can they do to help?
That's a great question. I think people are often scared to talk about any mental health topic, but especially eating disorders. People might feel they don't know enough, or it's not severe enough, or they might have some of those stereotypes in their mind. It's enough that you care. It's enough that you want to be there for someone and are noticing that something is wrong. And what I encourage is that people do not mince words, that they're direct. I am noticing this is happening. I am noticing you are going to the bathroom all the time after meals. I am noticing that you have lost weight. And I'm saying that in a way with care. I'm noticing that every time you look sad, you turn to food. And I'm wondering if you think that's an issue for you. And coming at that from a place of non-judgmentality, a place, it can be hard for people who don't experience eating disorders to understand, well, just eat, right? Yeah. Just eat, or just stop doing the behavior. Just stop. It's hurting you. I don't want you to hurt. And if it were that simple, it would be that simple. Yeah. So really expressing also practical help. Can I look into finding a therapist for you who specializes in eating disorders? Can I find a dietitian for you? Can I come with you to that first appointment? And also, I want to add here that denial can be sometimes part of the disorder, right? So even in that first conversation, if the person comes back and says, I'm fine, because there is this common misconception, not misconception, but more common belief in eating disorders that someone's never sick enough to get treatment or deserve treatment, or they don't look the case. So someone could have what we call a typical anorexia, and they're not technically underweight, but they've lost a significant amount of weight, and they're still struggling. So I don't look like that stereotype. I don't deserve treatment. Therefore, I'm going to push away people asking me for support. But what you're doing is you're planting a seed. And maybe another person will plant a seed. And maybe at that point, the person will then seek treatment and know that they have you there as a non-judgmental support person who really cares.
Just as a follow-up, are there, besides the strategies that you've shared in your experience, when is it that people will bring themselves into treatment? When does that happen? So this is families sort of reflecting, or friends, people who care and love the individual. But when is it that people bring themselves into treatment?
It varies, right? It varies at the age of the person. Mm-hmm. Oftentimes, parents bring their children into treatment, yet I've seen many adolescents who say to their parents, I'm struggling. Mm-hmm. Right? They're starting to notice a pattern. Maybe they're feeling more tired. They're feeling some medical complications. They're feeling distracted at school. Something is getting compromised that they care about. Mm-hmm. This can happen in college students as well. They're in college to pursue an endeavor, a major that they really care about, and all of a sudden they can't get their schoolwork done. Right. I see this sometimes right before people are trying to get pregnant, trying to address the eating disorder so they don't go into pregnancy and therefore after that parenting with the same disordered thoughts that maybe they heard at some point in their life. In middle age, people come in related to perhaps some type of medical complication seen at a PCP visit, or after a divorce, or after a lifetime of exhaustion of these thoughts. So for some people, eating disorders have a large degree of denial. For other people, it's more like they don't know any better. They don't know that there's a better way to feel. And sometimes what I'll see in my practice, people will come in for anxiety or perfectionism or ADHD, and then we'll discover after some months together, what's going on with your food? Right? And we'll start talking about it, and they'll say, I never thought I had an eating disorder. And then they start working on it and say, oh, I just thought I had to be this way my whole life. Right? So a variety of different pieces, and usually varying degrees of motivation, but anyone can come in the door at any time.
So once people come in, no matter how they've gotten there, whether it's by a friend, family, themselves, what does treatment for an eating disorder look like?
So best practices with eating disorder is a multidisciplinary team. So that involves some type of eating disorder specialist, therapist, that can be psychiatrist, that can be psychotherapist. It also involves an eating disorder specific dietitian, not just a general dietitian, eating disorder specific dietitian. I want to also make sure you have a medical provider to monitor any type of medical complications. And then some type of psychiatrist on board to monitor medications for any other mental health conditions or specifically for the eating disorder. Co-occurring disorders are very common in eating disorders and important to be treated concurrently. Once someone comes into therapy and into this treatment team, nutritional rehabilitation is usually the first step. So that means getting someone on track eating 3 meals, typically 3 meals, a couple snacks per day. That is irregardless of the disorder. For people who are underweight or under eating, they're going to need to be eating more food at the beginning, which can be really difficult, of course, and requires a number of different therapeutic approaches. In adolescence, there's an effective model of treatment called family-based treatment, where parents temporarily take control of the food, so actually plate the food for their child and sit with them and encourage them while they eat the food. And the therapist is the coach of the parents. It's a real parent-driven approach, and the therapist is there to support the parents. And this can be a really effective way to nutritionally rehabilitate someone who is at risk of hospitalization and to avoid a hospitalization, which could have its own challenges and for some people trauma. So family-based treatment is one of the popular therapy models out there. Cognitive behavioral therapy for eating disorders is a specific model of CBT that addresses the over-evaluation of shape and weight. It addresses the thoughts, the ideas around food, the rigidity, the inflexibility. It also has a part around perfectionism. And there's some research that shows if we treat the perfectionism, someone has a better chance of a full sustained recovery. So I always include that in my treatment. Dialectical behavioral therapy is another model that addresses coping strategies for dealing with emotions. So if your go-to for dealing with emotions is restriction or binge eating or purging, you need to build some other skills in there. So DBT can be really effective with that, especially for bulimia and binge eating disorder. Learning principles of intuitive eating might come at a later phase for some people, or right away in terms of binge eating disorder, developing more flexibility with food, having food freedom, legalizing certain foods that would be really scary to eat. Say if you've only binged on a food, you're going to try to have it at a snack earlier in the day. And then developing a value set around your life and your connections and your relationships outside of food and eating, because we know it's not just about the food, right? It runs much deeper than the behavioral and the thought characteristics. So sometimes then it involves looking at co-occurring disorders, treating, maybe there's OCD, maybe there's trauma, ADHD, depression. So making sure we're addressing all of that together so someone has a full and lasting recovery, not just reduction of symptoms.
Right.
Yes. And what are the risk factors for eating disorders? And are there any effective ways of preventing them?
Yeah. So there are certain risk factors that biologically include having a first-degree relative with an eating disorder. Also having a relative with any type of mental health disorder is a risk factor. Perfectionism and anxiety, especially childhood anxiety, is a risk factor for eating disorders. So additional risk factors for eating disorders include being a target of bullying, especially being bullied for one's weight or appearance. Being in a average or higher weight body does increase the risk of eating disorders. Weight stigma, again, pervasive in our culture. Limited social networks, so isolation, as well as any type of historical trauma, which can carry over from generations. And that appearance ideal idolization, right? People who are exposed to that in our culture, maybe exposed to that in people around them, are all different risk factors, as well as behavioral inflexibility. So someone who maybe from a very young age might say there's one right way to do something,
Right.
has a higher risk factor. And then what you mentioned about preventing eating disorders, given these risk factors, there's something I want to emphasize here because it comes up in my practice. Like family members, loved ones will say, what could I have done to prevent this? And feel a lot of guilt and shame. And for some people, there's just nothing that could have done. They develop the eating disorder, it's here, and now we treat it. However, what can we do to prevent it from fully developing, from getting worse? So we can have regular screenings. We can screen better as providers, right? We can move away from, again, praising people based on their appearance. We can intervene earlier. And what I mean by that is that maybe sometimes parents will say, oh, my child doesn't actually have a full eating disorder. I'm just going to wait and see. Or maybe, someone they consult professionally will say, let's just wait and see how this goes. There's actually some case studies that show if we intervene sooner, then we have better outcomes, and the person doesn't necessarily have to go a full-blown course of treatment or hospitalization or any type of further damage into the eating disorder. We can address co-occurring disorders earlier. So say you notice in your child or your loved one OCD, anxiety, treating that, then therefore is going to decrease the risk for the development of an eating disorder.
So what are some of the current barriers to accessing treatment for eating disorders?
So unfortunately, there are a number of different barriers, and they can be broken down into different categories. One is systemic.
Yep.
So we frankly don't have enough treatment centers. We don't have enough treatment providers. People may need to travel outside of state, which means they might have to take time off work, whether they're parents or they're the individual. They might lose their job and therefore then lose their health insurance. the health insurance itself, the system in terms of covering eating disorder treatment, has historically not been too kind to patients with eating disorders. The worst tragedy I've seen is someone going to a treatment center, getting that courage and vulnerability to say, I need help, I'm deserving of help, and then they're released too soon because of insurance. Mm-hmm. And there's a lot of good groups in the country working on this, yet it's still a battle. Mm-hmm. Cultural barriers can include people's families or certain ethnicities saying, well, we don't have eating disorders, right? That's a white person problem. That's not anything that we deal with in our culture. So then someone may not identify or believe that they have an eating disorder. Additionally, people with eating disorders may feel a lot of shame, may feel the fear of being judged, may not know where to go, who to talk to. Making that first call to a provider is so scary, right? And this American idea that we have to do things on our own, right? That we can't ask for help. There can be healthcare barriers. So a lot of treatments have been designed for white women. And sometimes treatment effectiveness doesn't translate to people who are transgender or of different races or ethnicities or live in larger bodies, right? So that is another barrier in terms of the treatment system. People may have had negative experiences in previous treatment centers or previous therapists and may be reluctant to seek help after that.
So for those listening and wondering if they might have an eating disorder, what would you recommend is their first step in seeking help?
I think it's really brave to self-reflect and even think of that question. To wonder, is there something going on with me? And usually if that question is there probably is. So not to doubt oneself. So this could involve asking someone you care about would you sit with me while I look through a therapist referral site? Would you come with me to that first appointment? Again, reaching out to a specialist, making sure you're seeing an eating disorder specialist, a therapist, psychiatrist, dietitian. I would say PCP, except PCPs do the best they can, and the training they get in eating disorders is very small. But if you have a trusted PCP, that is someone you could go to and say, I want a referral to an eating disorder specialist. Again, it's this idea that you deserve more than what you're living with. This does not have to be the rest of your life. Just because we live in a culture that's disordered doesn't mean that you can't feel better and that your eating disorder isn't real. Oftentimes, when I work with folks and they achieve this strong recovery, they are not the ones at work talking about their diets. They are the ones moving on and thinking of other things and living their life and having meaningful relationships and progressing beyond that common disordered eating in our culture.
And for our listeners in Rhode Island, would you have any recommendations of where to find care for an eating disorder?
Sure. So Hasbro Children's Hospital has an excellent eating disorder clinic that's available to adolescents and children. They have a partial program there as well. For adults, we have an intensive outpatient program. I think we actually have two at this point. One is B Collaborative Care. Another intensive outpatient program that has opened up in Rhode Island is called Bayberry Center for Eating Disorders. And then you can locate individual therapists through therapy networks such as ZenCare, Psychology Today, or academic centers such as Brown.
Oh, yeah. Excellent.
And for those listeners who are living outside of Rhode Island, are there any national resources?
So nationwide resources is the National Alliance for Eating Disorders, has a wonderful amount of education, resources, and also a helpline. The National Association of Anorexia and Nervosa and Associated Disorders, abbreviated as ANAD, is another useful website. And then, in fact, local to us up in Newton, Massachusetts, there is MEDA, which is the Multi-Service Eating Disorder Association. They have resources, they have professional resources, they have support groups. They're just a wonderful organization.
So one of the things I wanted to get back to that we were talking about was families and this complex treatment of here we've identified someone who is struggling with an eating disorder. And now the intervention, the standard of care is to involve the family in that treatment to do monitoring of meals. And that requires a lot of time, a lot of effort, a lot of emotional energy, and can set up a disagreement between everyone. It can set up, the therapist is now prescribing this rigid structure to help get them better. The patient feels controlled in a way, and they're trying to fight against that control. And the parents or loved ones are having to insert control where they may not have before or been very uncomfortable with it. And that sets up a very complicated dynamic in this standard of care treatment. So I wonder if you could talk a little bit about that, how that goes, and just try to demystify that a little bit. Let's open up the door of the house and look in and see what does that really look like?
Sure. In family-based treatment, there is an initial encounter where we really emphasize the seriousness of the disorder, how life-threatening this eating disorder is, as life-threatening as cancer. So the treatment that requires all this emotional energy, all this time, and privilege, right? Privilege to be able to take time to do this, and not all families can, and there are other treatments that we can use to really bring parents into this idea that this is critical. We don't throw parents into these situations without guidance and support. We actually do a family meal together where the therapist is observing what's happening at the meal. This can be done virtually. This can be done in person. This can be done in the home. And from there, the parents are taking this power role. And for a teenager, you can imagine how that goes. Clinically, I see that it goes better when the teenager is younger. It sometimes is much harder when the teenager is older, and we have to sometimes adjust treatment. If there are families where there is a high expressed emotion, sometimes this treatment model is not going to work. If there are families where there's abuse, we do not want to do this treatment model. Where there are families that have the capacity, have the resources, have the emotional bandwidth, and can access that support, this model, again, can keep people out of the hospital where a nurse might be doing this, or a medical professional, and the child will be separate from the family and lose that connection. So there is flexibility in family-based treatment. There's not necessarily a prescribed meal plan, though dietitians can be involved. But in traditional FBT, parents are feeding the child as if they were feeding them as they were growing up. We trust the parents. You got your child this far. We trust you to feed your child through this. And then there's a big emphasis in therapy on validation and support. So what this would look like is the child is having a hard time, the adolescent's having a hard time, saying, I know this is really hard for you right now. I appreciate everything in your brain is telling you not to eat this. And I want you to eat one more bite. So statements like that, coaching parents, and usually in the beginning, there is conflict, there is screaming, and we do a lot of externalizing of the eating disorder. So this is your child, and then this is your child's eating disorder voice. And there are flexible ways to practice FBT. Now I'm moving away from the standardized protocol to what I've seen clinically useful. And that is also checking in with the child and doing sessions with the adolescent to see how they're feeling through this, integrating some models of CBT, DBT, making sure they're feeling like they have a voice and they're not just an object in this. And paradoxically, sometimes families grow stronger through this treatment model. Wouldn't seem like that at first, but there becomes this trust, this support that the parents are going to be there no matter what. Even if the meal takes 2 hours. The parents aren't going away, and they're, again, this loving presence. What we have to watch out for is parent burnout. Parent burnout is a big deal, and FBT definitely raises that risk. So in some places, including locally, there are parent support groups where parents doing this model can come together and talk about it.
That's helpful, yeah.
With each other. And concurrently, they have the adolescents meeting together and they can all complain about the treatment model and complain about how they're feeling. And some people just don't have good experiences with this. Some people, I've seen them be on the verge of hospitalization and get better through FBT. And then their eating disorder remits and they go on and live their lives. So it's certainly the best we have right now, and we can do better. And I've heard that from the creator of this model.
Right.
Oh, I see.
Yeah.
And what would be the alternatives for families that unfortunately do not have the socioeconomic status that would allow the parents, for example, to quit their jobs, to be so active and present, monitoring what their kids are doing or preparing the meals? What would you suggest and what is done in the practice?
So alternatives include cognitive behavioral therapy, dialectical behavioral therapy, still involving families. I've certainly worked with a number of adolescents who, for the instances you just described, cannot do FBT or are not good candidates for FBT, and that's okay. And they still get better, and they still may have to work from a different angle, especially if their brain is malnourished and they're not able to think as clearly. Some of the cognitive behavioral skills aren't going to work as well until we get that nourishment in. But we can work on that behavioral inflexibility. We can work on getting enough meals and snacks in. We can use different apps like Recovery Record where I can see what they're eating, the dietitian can see what they're eating. That embeds certain skills in there and prompts them to use DBT skills, to use different strategies. And it's a way of accountability in between sessions. And I find that works really well with adolescents who are on their phones anyway, and wanting to share. And it's just more of a warm way to build change. And then I, again, still involve parents having family sessions, every so often, to make sure parents can also emphasize the skills that we're doing in session. So I'll send them those different skills. They can practice them at home. People still get better through all these different models. FBT gets a lot of clout, and it is a very interesting model. And people and teenagers and families can get better through these additional highly effective models as well.
You mentioned earlier about externalizing the eating disorder. So separating the child from, for instance, their eating disorder thoughts. I was wondering if you could just share a little bit more about that and maybe provide an example.
Absolutely. So oftentimes eating disorders come in and, like many mental illnesses, take over one's sense of their identity. Or someone would be acting in a way that is uncharacteristic to who they are. They might show a lot of increased emotions or emotional outbursts and say that's not like how they are usually at baseline. So borrowing from narrative therapy, we take the eating disorder and say that's the eating disorder voice. That is the part of you that is coming in and telling you you're worthless, or telling you that you are only worthwhile if you are a certain weight, shape, or size. So an example of that could be someone is having a hard time at a meal. They're saying, I don't want to eat this. I hate you. Why are you making me do this? You're the worst parent in the whole world. And the parent internally regulating themselves, saying, okay, my child is having a really hard time right now. That is their eating disorder voice. Wouldn't necessarily want to say that in the moment. It might feel invalidating to the child, but it's more for the parent's ability to say, that's the eating disorder. When I've used this with young adults, sometimes they name it the bad voice or Ed or any other type of name, just to separate in their mind what is the eating disorder and what is their healthy voice.
So we've talked a lot about what treatment for eating disorders might look like in the home. But as we all know, we spend quite a lot of time, if you're an adolescent, at school, or as an adult in the workplace. So what might this look like at school?
So in school settings, there are certainly areas that schools perpetuate weight stigma, and I've even heard of weighing at school, or lessons on good and bad foods, even as early as preschool. So ways we can intervene in school settings is really teaching about body diversity, teaching about all foods fit in a healthy diet, teaching students, including an anti-bullying curriculum around how do we treat each other. For teachers, yet teachers can be such an incredible resource, especially if there's maybe challenges in the home, having that relationship with the teacher that someone can confide in, even when they're going through an eating disorder, right? Maybe their relationship is with the school nurse because that's who they're sitting with and eating with. Yet the teacher is the one that's maybe not seeing them as a patient.
Right.
The teacher is the one that's seeing them as an excellent math student or an emerging scientist. So that is one area in school, and extracurriculars and coaches I've also seen to be wonderful resources, especially if they're offered some education and some guidance around what's can be supportive. So college is another major risk factor for people developing eating disorders. Adolescence is an early risk factor. Other stages of life are risk factors. But in college, there is so much disorganization around scheduling, eating, substance use, body comparisons. People are suddenly surrounded by people who are their same age and may ascribe to that thin ideal. And then they don't have that typical support system. Say they come from a family that's been maybe watching and keeping an eye on them, and they are in this level of stress, or maybe they have some undiagnosed ADHD or some type of mental health disorder, and then they try to manage it by engaging in an eating disorder. So college is another great opportunity for someone to seek treatment. Colleges tend to do a lot of awareness at this stage of the game in terms of making sure there's accessible treatment, given the prevalence of eating disorders on college campuses among all types of people. And it is a way someone could strengthen their recovery and also provide a guide into the rest of their life. If they move beyond this eating disorder, do they have to interrupt college, or can they get treatment sooner? Some people do need to take breaks, and that's okay. But college can be a really big motivator for people with eating disorders to say, I want to get through college. I want to get to the other side. Some people, I want to help other people who've been through what I've been through. And I want to use college to get there.
And how about work environments? How does the work environment and the culture in the work environment can affect someone with an eating disorder? And what can we do to change that?
So workplaces are quite interesting. They can be places of social support. They can be places where there are fitness challenges and people earn points for losing weight collectively. And imagine having an eating disorder and trying to recover, and that is the talk and the emails that you're getting. Conversely, eating disorders and people with eating disorders can benefit from social settings. So those social cues to eat together.
Right.
So if you're in a healthier workplace and you have the time to sit down and have a meal together, or even that cue, the cafeteria is open from this time to this time, go down and get food and eat together, talk together. It can be a place where people seek social support or see themselves and their sense of identity outside of the eating disorder. So it can toggle back and forth, right? And it's something that people with eating disorders need to be sensitive to. Am I going to participate in this fitness challenge, even if it doesn't have a weight component, or will that be triggering to me? Workplaces, can we design ways to promote health and to promote well-being without it being focused on weight?
I wanted to ask you about BMI, or body mass index. This is the chart that we're all kind of familiar with. We've all seen. We all get compared to what's your height and what's your weight, and here's your corresponding body mass index number. And they're associated with terms if you're underweight, if you're normal weight, if you're overweight, if you're obese, or if you're morbidly obese. And this chart, I'm sure, has very good intentions, but it's good for most, but not for all. And so I wonder how this affects treatment with eating disordered patients. And because I think there's other people that it doesn't quite help, but since this is what we're talking about, I wondered your opinion about the BMI, the body mass index rating, and in use with eating disordered patients.
Yeah, so BMI, like you shared, is a fairly reductionistic measure. It just looks at someone's weight and their height, doesn't look at their body frame, their muscles. We tend to use it a bit more in restrictive eating disorders when someone is underweight. Insurance companies use it. That's just a reality of what is happening right now. We also use growth charts, and that can be a really wonderful alternative to BMI to see where someone is according to their normal growth chart. And then when they dip, perhaps with the eating disorder, no matter what their BMI or weight. And then BMI, unfortunately, can be quite damaging if someone is at a quote unquote normal BMI and they're suffering from anorexia. So that typical anorexia. They may think, oh, I actually don't have an eating disorder because I just went to the doctor and my BMI shows that it's average or high. Insurance companies can also use this to deny treatment, unfortunately. It's oftentimes more harmful in eating disorder treatment. And that is something that is widely talked about among my peers.
Yeah.
And quite complicated.
Yeah.
Thank you very much, Brooke. This conversation was really helpful. We appreciate you joining us today. Now, a take-home message to bear in mind.
Eating disorders are a serious mental illness with potential serious impacts on both mental and physical health. Eating disorders can affect anyone from any age, race, ethnicity, or gender. However, there are things we can do as individuals and as a community to help identify and support those at risk. We can learn how to identify signs that someone may be at risk and understand the resources available in the community to help. We can also learn to help each other by being mindful of how body image ideals portrayed in the media can impact our self-esteem and help challenge these ideals to promote healthy eating and body image in ourselves and those around us.
If you or a loved one are struggling with an eating disorder, we encourage you to share these concerns with your doctor. You can find more information about eating disorders and treatment options near you through the National Alliance for Eating Disorders and the National Association for Anorexia Nervosa and Associated Disorders, or ANAD.org. If you are interested in prevention efforts, please check out The Body Project, which is a group-based intervention for high school and college girls to help confront unrealistic body ideals and improve body image and self-esteem. So if you or someone you know is feeling unsafe, please contact the Suicide and Crisis Lifeline, call or text 988, or access 988lifeline.org, or go to the nearest emergency room and ask for help.
Thank you for listening to our podcast. For more information related content, please check out our Instagram, Facebook, and YouTube channel. Bear in mind the Brown Psychiatry Podcast. Thank you.